Hello, I'm Dr. Cassie Yu for the Joint Telepsychiatry Toolkit of the American Academy of Child and Adolescent Psychiatry and the American Psychiatric Association. I'll be discussing the use of telepsychiatry to treat disruptive behaviors disorder by providing behavior management training to parents. Approximately 1 in 11 children ages 3 to 11 exhibit disruptive behaviors disorder, but only about 20% receive the recommended evidence-based treatment, which is behavior management training. Well-known examples of these interventions include parent-child interaction therapy, the Incredible Years, and Positive Parenting Program, otherwise known as Triple P. Collectively, they have demonstrated large and sustained effects in treating childhood disruptive behaviors. However, they're largely unavailable in community settings. Therefore, telepsychiatry holds potential to disseminate behavior management training from academic and major mental health care centers to families in diverse settings. Behavior management training refers to behavior-based interventions that help parents to reshape their parenting practices in order to decrease negative childhood behaviors by fostering self-regulation in children. Examples of the core concepts that are readily implemented through telepsychiatry include active ignoring, labeled praise, and child-centered time. Active ignoring refers to deliberately ignoring minor misbehaviors such as tantrums, whining, and complaining. Parents worry that maybe they're not bonding with their children or teaching them when they're ignoring these negative behaviors, but really they're helping to promote self-regulation. When children are given the opportunity to learn to cope with small disappointments, they're actually learning and developing the skill of self-regulation. Ignoring the whining behavior of the child demanding a candy bar is actually an opportunity for the child to self-regulate while being guided by their parent. In telepsychiatry, an anxious child may whine and look away from the monitor while the psychiatrist and the parent discuss the child. The psychiatrist can coach the parent to ignore this behavior and continue to proceed with your session rather than to soothe their whining child. When the child stops whining and re-engages in a positive manner with the psychiatrist and the parent, the psychiatrist can provide descriptive praise for that positive behavior. Thus, labeled praise refers to giving praise specifically by describing the child's behavior. Instead of generally praising a child by saying, "Great job," the parent is coached to praise with specificity. In other words, "I appreciate how you put away all your toys and neatly made your bed." This type of parental attention can serve as a great motivator for children to complete unwanted tasks that require self-regulation. Coaching parents to look for opportunities to praise their child can be practiced during telepsychiatry, similar to practice in an office setting. The psychiatrist can then model labeled praise in vivo during telepsychiatry by describing the child's patient behavior, which reinforces this concept for the parents. For instance, after helping a distracted child to re-engage, the psychiatrist may say, "Thank you for looking towards the camera. You're showing me that you're really listening to me." Labeled praise is often taught in conjunction with teaching child-centered time. Child-centered time is protected time with your child that is consistently scheduled, even if only for minutes. During child-centered time, parents interact with their child in a very specific manner in which the child takes the lead in play. This means that the child gets to choose the activity and make up all the rules as long as they are safe and appropriate. The parent learns to observe how the child directs their preferred activity using their cognition and imagination. During a telepsychiatry session, a psychiatrist can observe as the parent engages with their child in this way and provide in-sync coaching to the parent to abstain from correcting, teaching, or testing their child. Talking to parents about their parenting can be challenging, and it is no different in telepsychiatry. It is not yet clear whether the needed collaboration with parents is compromised when delivering behavior management training by telepsychiatry instead of in person. To guard against any possible compromise, care is needed to ensure that parents do not feel judged. Talking slowly, leaving plenty of time between sentences, and soliciting the parent's input helps parents to process information that may be contrary to their usual parenting practices. There are a few differences in delivering behavior management training in a clinic versus at home. In clinic-based behavior management training, the psychiatrist may consult with clinic staff regarding aspects of the child's presentation that may be difficult to appreciate through video conferencing, such as subtle body language, eye contact, changes in facial expression or response to a non-family member. In home-based behavior management training, additional care is needed regarding safety. A written safety and crisis planning is developed to guide the interventions should a crisis develop, such as a child eloping or an injury occurring during a parent-child interaction. A safety plan should include a contact list such as local emergency responders, primary care providers, and trusted family or friends. Parents may require guidance in operating their equipment and choosing the optimal site for telepsychiatry sessions. Overall, the focus of behavior management training, which requires observable parent-child interactions, allows psychiatrists to use telepsychiatry to help parents shape their children's behavior and development. I'm Dr. Cassie Yu for Telepsychiatry Toolkit. Thank you for watching.